Dr David Oehme here. I'm a neurosurgeon and spine surgeon based in Melbourne, and today I'm going to be talking about surgery to treat a cervical disc herniation or disc prolapse in the neck. This is a really common operation that spinal surgeons do, and it's very effective at treating the symptoms related to a cervical disc herniation. Now, when we talk about operating on a neck, there are really two different approaches that a spine surgeon can take. And the simplest way to think about it is one approach from the front and one approach from the back. Now, by far these days, most of the surgeries that we do in the neck are through an incision in the front of the neck. And although that might sound a bit scary to patients, it's actually a really simple and straightforward way to approach the spine. Now, the discs are actually at the front of the spine, and this is why it's a much better approach going from the front, because it allows us to get direct access to the discs. Surgery through the front of the neck is otherwise known as anterior cervical spinal surgery and is a really common way to approach the spine. Surgery is performed under general anaesthesia, so patients are asleep and have no awareness for what is going on. A small incision is made in the front of the neck. Once we've made that incision, we carefully retract on your esophagus or food pipe and your windpipe, also known as the trachea, to get access to the front of the spine. Once we've done this, we have access to the intervertebral discs and the vertebral bodies, which allows us to operate on the symptomatic level. Once we've identified with X-ray the symptomatic level, typically the next step of the operation involves placing retractors. We then, using a microscope, we aim to remove the disc which is herniated. We remove the entire disc. Once we've removed the entire disc, we can then take the pressure off both the spinal cord and the nerves going out to your arm. Now that's the critical part of the operation. It's relieving the pressure on the nerves, which will help patients get relief of their symptoms. If we don't do this job properly, it's likely the patient still might have recurrent pain after the surgery. Once we've removed the pressure on the nerves, we then face a question: what are we going to do to put in place of the discs? Now there's really two different options. If we put nothing in between the vertebral bodies, then the two vertebral bodies will collapse down on each other. Now this is a bad option because it'll further narrow the space where the nerves are going out to the arms. So we need to put something between the vertebral bodies, which is going to keep the vertebral bodies apart and maintain that disc height. Now there's two options. The first is a fusion device, and this is called ACD or ACDF, anterior cervical discectomy and fusion. The second option is to put in a cervical disc replacement. Now this is not a fusion, this preserves motion. Now a lot of patients have a misconception that the fusion is the bad option and the disc replacement is the good option. This is not the right attitude. Both are really good operations. It's a question of what your symptoms are, what the problem is that we're trying to treat, what is the best option for you. Once we've put the implant in, we're then using dissolvable sutures, close the skin over the neck, and then the patient typically goes home after 1 to 2 days. A big question with anterior cervical spine surgery comes as to what is the better device to put in. Should we put a fusion device in, or should we put a disc replacement in? Now a fusion device involves putting an intervertebral spacer in with bone graft in it that then causes bone to form between the two vertebral bodies. Often we'll put a small titanium plate over the vertebral bodies to further fixate the level. Now obviously this eliminates movement at the level. Now the disc replacement is the opposite. Instead of putting a device that eliminates movement, we put in a device that preserves motion. Now instinctively, we all think that preserving motion is the better option, and in some patients that it is. But there are different reasons why we might choose to do a fusion versus why we might choose to put in a disc replacement. The risk of doing a fusion is that by eliminating movement at that level, you can put stress on the discs above or below the fusion, which can cause discs above or below to wear out. This is what we call adjacent segment disease. Now in a fused level of the spine, the chance of the level above or below wearing out is about 10%. The concept of the disc replacement is that if we put a motion preserving device in, that we will put less stress on the levels above or below, and this will have a less chance of needing surgery at one of the other levels in the future. And this is true. Now, there are downsides to both. The risk of putting the disc replacement is that there's a higher chance of neck pain occurring. Now, if you're a young patient that has an acute disc prolapse at one level, you don't have a lot of neck pain, the other levels of your spine look healthy, then putting in a cervical disc replacement is a great option. If you're an older patient and you have problems at multiple levels, you have arthritis in the joints at the back of the spine. If I put a disc replacement in you, it might mean that you have a lot more neck pain after the surgery. In these types of patients, it's often much more effective to do a fusion so that they have much less post-operative neck pain. If you want more information about the benefits of a disc replacement versus an anterior cervical fusion, check out my website www.doneurosurgery.com.